Good afternoon, everyone. Thanks for joining. I'm going to give it a few seconds as folks get their audio connected. Welcome, welcome. Sure, in there. All right. We'll give it another minute before we get started. Okay. Well, good afternoon, everyone, and welcome to the fourth and final part of our Strategies to Reduce Environmental Cancer Risk webinar series. My name is Caroline Powell. I use she, her pronouns, and I am the staff lead for the Iowa Cancer Consortium's Cancer and the Environment Task Force. Feel free to use the chat to introduce yourselves or drop any questions you may have for our speakers throughout their presentation, and there will be time at the end for a Q&A as well. So we have participants joining us today from various areas of expertise across the country. So for anyone new, the Iowa Cancer Consortium is the state of Iowa's comprehensive cancer coalition of over 650 members. And we are a nonpartisan, non-political organization, and we do not use state or federal funds to engage in lobbying. And the opinions and interpretation of the information shared by speakers and attendees in this webinar series do not necessarily reflect the positions of the Iowa Cancer Consortium, its board of directors, members, or staff. The consortium's Cancer and the Environment Task Force's role is to connect partners with resources, knowledge, and collaboration opportunities that help them succeed in practicing cancer control work through an environmental and occupational health lens, and vice versa. And now our Year 1 CDC Public Health Associate, Brianna McNulty, will introduce today's speakers.
Hi, everyone. As Caroline said, I am Brianna McNulty. I use she, her pronouns as well, and I am the Year 1 CDC Public Health Associate here at the consortium. So I have the pleasure of introducing two members of Mahaska Health's Occupational Health team in Oskaloosa, Iowa. Dr. Kymberly Life is an internist by training and enjoys working with her patients to determine the best treatment plan that fits their needs. Dr. Life is certified by the American Board of Osteopathic Internal Medicine with a certificate of added qualification in occupational and environmental medicine from the American Osteopathic Board of Preventative Medicine. Dr. Life values the importance of a healthy lifestyle and when not at work enjoys spending time outdoors and riding her bike. Arthur Zacharjasz, Arthur grew up in Illinois and worked as an intensive care unit nurse at Northwestern Memorial Hospital in Chicago. Arthur graduated with honors from DePaul University with a Master of Science in Nursing and went on to earn his Advanced Registered Nurse Practitioner license from North Park University School of Nursing. He is currently a PhD student at the University of Missouri-Columbia, where his research interests include rural health, social determinants of health, and health equity. In his free time, he enjoys the disc golf course at Edmondson Park, reading, and spending time with his family and wife. And with that, I will let you guys take it away.
Thanks for having us. We're going to kind of be alternating speaking. If you want to chime in, please go ahead. It's about 15 minutes, and then we'll have plenty of time for questions. All right, we don't have any financial disclosures. And so today we're going to be really just covering conducting exposure history and what that kind of entails, and we'll get to some real-life examples and kind of what we do. I mentioned some of the objectives there, but we really want you to kind of understand the key components of an exposure history, how you conduct one, and then kind of putting it all together for intervention development. So why do we take these? Exposure histories are really essential for identifying potential toxic exposures. They can contribute to cancer and other health risks. They help diagnose environmentally related illnesses, guide appropriate treatment, and also reveal opportunities to reduce future exposures.
Hazardous exposures from environmental and occupational sources can often show up as common medical problems with nonspecific symptoms and An accurate and complete exposure history is the most important tool in evaluation, diagnosis, treatment, and prevention of occupational and environmental illnesses. A comprehensive exposure history has three main components: the exposure survey, work history, and environmental history. We'll show you each one of these. So a self-administered questionnaire may be used to capture an expanded and detailed occupational and environmental history. If answers to the survey are positive, a more detailed follow-up questioning is needed. On the screen is an example of the exposure history form from the ATSDR CDC site, which can be downloaded. A comprehensive exposure history.
Oh, we do this. I'm going backwards. Wait,
Don't do that.
Canva got me. Okay. So the exposure survey captures details on known exposures to hazardous substances, including routes of exposure, frequency, duration, use of protective equipment, and any symptoms that may be related to the exposures. The work history provides a detailed account of all jobs held, industries worked in, specific chemicals or substances used, and workplace safety practices. This can reveal occupational exposures that may not be apparent to the patient. The environmental history explores potential exposures in the home, through hobbies or recreational activities in the community, and through diet and lifestyle factors. This provides a more complete picture of total exposure burden.
When conducting the history, use a standardized form or questionnaire as a guide. Ask open-ended questions, none in a non-judgmental way, and probe for details. Look for the relationships between the time of exposures and onset of symptoms. Be aware that some of the patients may downplay risks due to protective barriers.
So when interpreting the data gathered, identify all potential carcinogenic exposures. And carcinogenic means kind of cancer producing. Consider cumulative and synergistic effects of multiple exposures. So things that kind of compound together and especially over time add to additive effects. Compared to established occupational exposure limits where applicable. We'll talk about those in a little bit. And then try to assess the patient's total body burden of toxicants.
Use the exposure history data to develop targeted interventions. Some of these may include recommending ways to reduce exposures, advising on proper use of PPE, suggesting workplace controls or substitutions for hazardous substances, and importantly, educating patients on modifiable risk factors.
So here, this is kind of our last slide here. So we're going to go over a few things. I'm actually going to, well, we'll start here in this slide. So Dr. Life, you want to talk about some of your experience in the ER?
I was in the ER for a lot of years. And one thing I started noticing was there was a lot of people coming in from a certain industry in town that had lung cancer. Also noticed that even some of the office workers had breast cancer. So I didn't really, as an ER doc, you don't really pay much attention to environmental or occupational hazards. But since then, I've started, thinking about what was the issue with working in the foundry. So after some research, I did find that there is a higher incidence of working in foundries and lung cancer in men mostly, and breast cancer in females.
We also, so part of our clinic, what we do is that we do not only pre-employment physicals, but we also do kind of like hazmat evaluations and respirator protection. And a big part of this is actually doing on-site kind of visits to determine what individuals could be exposed to. A lot of these industries have certain safety standards, and you may have a manager that may not have certain knowledge of, certain chemical levels they're getting exposed to, respiratory pathogens, inhaled substances at certain parts per million that could be toxic over time. And so really to have better insight, we'll do on-site kind of tours and see what workers they're exposed to daily. And one of the examples was in corn, what I think gets lost a lot is that we think of like an end product, like we see corn at the store or corn for fuel or for all sorts of things, but we don't see how it's made and the toll it takes on the environment to get that product. You look at the runoff of nitrates from hogs to subsidize farms, and then what leads to the cornfields, and then they go to plants and are processed. And sulfur dioxide is commonly used, it's added and to really prevent bacterial growth in corn hull, but also promotes softening of the kernels and for processing. And when we were at we were at a site. It's kind of like you see who can hang in that part or not based on how they can suffer through sulfur dioxide. In the first couple of minutes, I could feel my throat burning, and I felt like it was irritated, and then as well as rashes. And so you start looking at this, and the literature is everywhere on sulfur dioxide and does it cause cancer? What is the level of exposure? And part of the reason why we're doing this is you all that are here are really advocates in your communities to understanding and asking the difficult questions. One big thing is kind of Flint. Everyone's know about the water crisis, but you can see those corroded pipes. These were lead pipes that had corroded over time. And this really started in 2014. So kids started to get sick. People started to ask questions. And investigations were done, and it's still a problem. And if you listen to the testimonials of individuals, there's a couple of documentaries actually on YouTube. People were getting brain cancers, nine-year-old females getting reproductive cancers. And so this one physician, using the electronic health record, she asked the question. She wanted to know really what were the blood levels in children before and after Flint switched its water supply. And you can see that some of the communities had double or triple the lead levels. And this graph that's depicted there, that was in 2016 when it was above a certain threshold. There is no lead that's safe in children. And we know it's a neurotoxin. And you can see the increasing levels starting to rise again. And part of the reason is that, well, kids started getting gastrointestinal disease as well. And not only kids, adults. They started dumping a bunch of chlorine. Chlorine not only can treat bacteria, but it also erodes certain metals. And what started happening is it started oxidizing and causing THM, which are, oh gosh, trihalo. Let me look at it.
Trichloroethylene?
No, trihalomethanes,
Okay.
which are byproducts and have cancer risks. And so this intervention has caused more of a headache now instead of treating the actual root cause. And so there's other stories, like we work with veterans and we have to look at their exposure histories and be aware of, for example, Agent Orange. Some have certain, this was in Vietnam, but these are herbicides that some of the biggest chemical companies were producing and were authorized to produce. You look at also the burning pits, and more recent in Afghanistan, they were burning trash and fuels and not knowing what the servicemen are exposed to, and they end up having all sorts of cancers. And then as well as their families being impacted by reproductive issues. Where is my screen here? Let me get up. Give me 1 second. I'm going to show you. So we bring this up. I'm going to share. Not this. My other window. So in literature, when we look things up, and here's the article on, it's very, if you're interested in environmental health and whatnot, this is really looking at Flint, Michigan. It's shocking what's going on. It's still going on. And where is the outcry? And where is the support for the community? And these are lower socioeconomic individuals that don't have access to attorneys and legal defenses and are suffering. We mentioned sulfur dioxide. Part of it is that, well, if you look at the literature from the AATSDR, you look at it's from 1999 and it says it's not a carcinogen. Well, you look at more recent literature and you start to see that there is mortality associated with sulfur dioxide exposure in different industries. It's mutagenic by inhalation. This was in mice. And so a lot of the responsibilities of where we are staying on top of the literature so we can educate some of these industry partners about what their employees are getting exposed to, especially if they're becoming ill and we don't have a good, clear consensus of what's causing them to become ill. It may be their work environment, it may be other determinants of health in the community, it may also be a combination of those. I encourage you, if you're interested, do some digging. Part of our talk today is really to be kind of a resource and to show you that I wanted to show this glyphosate, which was produced by Monsanto, as formerly known as Roundup. You can look at, there's mixed evidence everywhere. And so when you make a decision for your community or for your job or for whatnot, you really have to have a fundamental understanding of what you're actually reading. And if it's an industry sponsored research or not. And so there are huge biases in the research process. And so part of our job is to be able to look at the research, make kind of clinical correlations and examine what is going on. And just because someone says that it's not associated or it's not causal, it doesn't mean that that's actually the reality. It means that that study in that one point in time didn't show evidence of that link. But it doesn't mean that in our community that cancer is not a real problem. We'll stop there and open up for any questions. I think it's almost 15 minutes there. So if you have any questions about what we do, any interesting stories, we'd be happy to discuss. And I think we have some questions also from the panel here.
Yes, thank you so much, Dr. Life and Arthur. And I just really appreciate you showing us how the research has changed over time as well, and just the importance of, people like us in our position who have access to this literature, reading it and staying up to date, because not everyone has access to that literature. So that's really important as well. And so some questions in the chat. Melinda is curious to know if sulfur dioxide is more likely to be used in ethanol production or food production, and are workers traditionally told to wear protective clothing?
So I'm not sure about the ethanol. I know only if it probably is, because it is used in. I know that some of the mills, what they use the corn and what it ends up being, and sulfur dioxide does exist, and sulfur oxides do exist in the atmosphere at all different kinds of levels. I'll actually have to get back to you about this specific. I haven't looked at the literature. They do wear now. In this part of the plant, I remember they did not have respiratory protection. So it was an irritant of the respiratory epithelium. And so they started laughing when, so some people can't even last 5 minutes in here. And I'm like, I'm like starting to get red and swallowing. I'm like, if you want those. And I'm like, wow, it's so irritating. I can't imagine being here for the next 10 hours. They do wear long sleeves. So some of the dermatitis is addressed by that. But this is one compound. And you also don't know what it's converted to based on other conditions where they're exposed to. And so we find various, the PPE that is worn and how it's worn, and ideally what it's protecting from, these are kind of ideal environments. And sometimes where a lot of the NIOSH stuff and respiratory protection, these standards come from the 70s. And so working conditions have really changed, and research is expensive. And if someone's doesn't have a business interest in it, it may not get funded. And so I think there is a lot of dogma in some industries. And we had the discussion about the vaping. I remember with the American Lung Association, we're having pushback about industry and whatnot. This is why your guys' voices matter, and this advocacy is so important. It's because these are real issues in our environment. Actually, Iowa farmers have a disproportionate amount of cancer, and how much is getting looked at that this is an environmental cause. Everyone assumes it's just they're smoking, but the reality is that there's more there. But to get these studies done will take a significant amount of capital. And if you have big lobbies like agriculture not really vested to have that, it creates kind of a complex environment. I don't know if you had anything to add. Do you know anything about ethanol? No. So sorry, we'll have to get back to you specifically about that link. But The best source, I think, if you're interested, is always starting to see if there's a meta-analysis or systematic review. So type in whatever interest that you're interested in. So you could do sulfur dioxide and ethanol meta-analysis or systematic review. This is what we can kind of consider. This is a review of reviews. And so it takes a lot of primary literature and it examines it and says, like, is there actually an effect size? And is there something to look at? And then you can kind of start digging there.
Thank you. And Liz wanted to know, with your example of foundry employees locally, were you able to do anything with the company to increase awareness or promote using the correct PPE or other interventions?
They're not one of the companies that we work with, so we haven't been able to influence them.
Yeah, I think one of the hardest things is that we always try to serve patients in the community. Business and administration, and I shouldn't say all, but a lot of them are obsessed about OSHA log and missed times and premiums on insurances. And so, it is sometimes more difficult to navigate if your partner is not as engaged or is not as, I think, receptive to digging and finding out sometimes more information. We're at a standstill. We can have all the support we want, but if they just want us to treat an acute injury or acute whatever, it's a little bit more complex to navigate these relationships. And some of these industries, these are international companies, and so it takes years for them to develop trust and and some have different, I guess, interests and understandings of potential exposures to employees, and they don't see sometimes the business case that a healthier, safe workforce is actually there's a huge ROI on that, and that can just be a knowledge gap and one that we have to kind of address. But yeah, that's one that we haven't cracked yet, and so it's a good question. So in short, no, we didn't do anything. we're still putting our heads together and trying to figure out. So
fair. Melinda would like to know, how often is the ATSDR supposed to be updated?
I don't know if they have a set time when they're updated. You can go through different articles and they will have the dates on them, but some of them are back to the even 1990s. So
I think every industry, so you look at toxicology, then environmental science has its own kind of committees and what they consider to be standards for the industry. A lot of it is there's not been enough new research to warrant a new position from that agency. Some of these agencies are underfunded or have been cut. And so that's why I bring up the ATSDR, is that, well, you look at some of the literature it's based on for like sulfur dioxide, it's just from 1998. And there's newer literature, but there haven't been a panel assembled to review that, likely because there's not much. And so you bring up a great point. I would say always check where it's from. If you're going to be using a tool or intervention, see that it's actually been tested, and it may not also translate to your context. We're a rural critical access hospital. Some of the things I want to implement and do, I have to see if they've been validated, because it may not actually capture what I'm trying to measure. Additionally, I always look at the tool I'm looking at, when was it created, and is there new literature to support its use, or is it outdated? And maybe there's actually better things that are in more recent literature that I have to look at and kind of, a lot of the time is you're kind of MacGyvering everything. You don't have the ideal tool. You're going to use part of this one and you're going to adapt it for your context. But as long as I think you can justify in some cases, there's some literature to support it, you're not completely off the rails doing something. And then a lot of what we do is discoverable in legal. And so we don't do anything just because I Googled it and I want to use this, whatever. It's like, imagine 30 years, someone got a cancer and I didn't capture it, or I didn't measure this, or I didn't do this properly. That's how I kind of operate. And so a lot of the things we do, they may be dated, but this is the best tool at the time that we have, and that will withstand a legal claim or something like that. So that's a good question.
Thank you. And so Audrey says, thank you for this work. A few questions here. Where do you go to learn about environmental health harms to apply in your practice? She sort of answers these two. How do you stay current in your field? And can you give some examples of what outreach to community partners looks like when you're educating about these harmful associations?
So I think the one thing we do is we look at what's specific for an industry standard. So like our community partners are employees that we actually see. So we see workers' comp, for example, we see pre-employment, and we also see like hazmat or PPE or respirator clearances. And so a lot of what kind of we kind of hone in on what we need to be current on. So for example, we know that this person had like a fluoride burn. So I know that like, hey, their SDS sheets, like I need to know like what kind of how to manage that if they were to come in with that, what a referral would look like to the burn center, what are things I need to be anticipating. And so then I kind of start looking at that literature and I have my kind of a catalog of like what's the current best practices, right? And so Dr. Life and I, oh, we had this case come in, they got exposed to whatever, sulfur gas actually, wasn't it something?
Right.
And so we know kind of like, hey, we have a great resource for sulfur gas. What does it mean clinically? And then prevention side, right? Was this an exposure that could have been prevented? And so when they do their kind of root cause analysis, they also will ask, hey, is there anything on your guys' end that you can think of that maybe, a safety route of PPE that could have been implemented and engineering control. We know that engineering controls are the best and most effective way of kind of preventing things from happening because the employee is not going to be exposed. But if you cannot engineer something out of there, and a lot of the places that we work, they've been in business for 100 years. So you imagine they haven't updated the machinery, the safety, the ventilation, the rest, there's a lot of things that haven't been kind of invested in because they're just working. They grow and they sometimes exceed their safety capacity. And so we'll come in and look at industry standards and say like, well, these paint booths, they're spraying all these polyvinyl chloride all over themselves. Where are their suits? They don't want to wear the suits because it's 115 degrees in the booth. I'm like, okay. And I made the business case of saying like, well, hey, if it's 115 degrees here, you've wasted their energy expenditure in the first hour of the morning. And so now you have a tired employee that's more likely to strain their back, not make it through the shift. They're losing productivity, and one injury will set them back 6 to 8 weeks. So you not investing in an adequate work environment is costing you much more than you're actually seeing. These are these indirect costs of these injuries and exposures. So I think a lot of ours is we stay current on what is expected of us because it's infinite, and we kind of curtail to what we're seeing in clinic, and that kind of spurs us to go and investigate. And I think the last part was oh geez, I talked so long I forgot the rest of the question. What does outreach look like when you educate? A lot of it is understanding the health literacy in your community. You can really empower individuals to information, but it has to be palatable. So if I'm blabbing on about, I don't know, some kind of medical process or some kind of exposure, is my message actually getting delivered? And so a lot of it is on-site visits, meeting with the workers, and then when we see them in the exam room, 5 to 10 minutes of just education. What you were exposed to, how does it work, things you can worry about, ways you can protect yourself in the future. And I think it's getting the safety individual. So it's usually HR and their safety teams involved. Do you have anything to add? So,
no.
Okay.
I think you've said it all.
Talked enough for both of us.
Yeah.
Thank you. And I guess a follow-up, like at Mahaska Health, how do you determine when to do an exposure history for a patient and when not to? Like, are these common for like a regular appointment, or does it have to be like Occ Health focused? How does that work?
Depends how much money they're paying us. No, it's they're not usually reimbursed and they can be comprehensive. And so I think the place we start is if it's a known exposure, we're kind of digging to make sure that everything they're exposed to, when and whatnot, we have an understanding of. If they're coming in for symptoms or they're not improving. So these can be more nuanced. Why is someone not getting better with the standard of care? Is it their lifestyle? They can't afford their medications. They don't have transportation to X, Y, and Z. So really these social determinants, we start kind of getting more creative and saying like, is it their home? You know, a lot of these individuals, we're a lower socioeconomic county. And so their homes may have hazards that we're not also incorporating. So they may be getting exposed to aspergillus just normally because they've got all these molds in their basement they live and whatnot. And now they've got an exposure or they develop some intrinsic lung disease from work and they also smoke. And so now it's like, well, now we've got the full play of, of a history to kind of go into. We have the luxury of we're not as busy as family med docs. And so we don't have 4 chronic comorbidities. So we're able to dig a little bit more. But the reality is the barriers, I think, is like time. If you have a 20-minute visit and you have to treat someone, how much are you going to be able to kind of get into their history? And a lot of times I think I have found in my experience is that patients may not find it relevant, but they don't understand the connection sometimes between their environment, right, and their medical history. And so it's kind of navigating that journey with them so they feel so I can kind of build those bridges and they can kind of see why I'm asking certain things. I don't know if you had that some similar experiences or
Thank you.
Dr. Life's got the next one. So ask her something hard.
Yeah, no, you're good. Well, I was actually just curious because I know in your bio it's mentioned that you have like a specific certificate in occupational and environmental health.
Right.
I'm just curious, like when you were going to med school, like was occupational and environmental health brought up a lot, or was that something that you sort of stumbled into? Like how did
More
that come
something I
about?
stumbled into after the ER.
Okay.
But once I got here, I just felt like I needed to be more educated about it. So I started looking around and found that I was able to get a certificate of added qualification. And I think I studied for about 1.5 years and did multiple required workshops and then took a test for it. So
That's helpful. And do you think like since you've gone through that, like are there more certificates available in that topic area? Like is it becoming more popular, or do you think folks are still hesitant to dive into it?
it really isn't something that people think about going into, at least when I was in medical school. I didn't even know it existed, honestly. So I think there's very few people going into it. And even for the certificate of added qualification, I think just very few people have wanted to tack that on.
To piggyback off of that too, we're paid as clinicians. I have a directorship. And so a lot of it's like, how do I justify spending X, Y, Z time, right? If I'm paid to see patients and what's the reimbursement? We don't bill insurances. And so what we charge the companies is a little bit different. And so it's very kind of industry specific, but a lot of OCMED physicians, actually, you can see them like on oil rigs, or they have like a company physician or something like that, and they weigh in on these safety protocols and screenings and prevention. I think environmental falls kind of by the wayside in a lot of, because it's dictated by what are you hired for? What is your actual return on investment? Versus you trying to address community interventions. And the biggest things that change population health, and I'm preaching to the choir here, are really kind of these systemic and policy level interventions. And that's kind of where I am focusing on to help beyond just one employer, right? And so this is why this work is important, and these conversations are important because there are real barriers that we face in healthcare. And so, but these are, I think it's undervalued, and a lot of it's because like, well, what is your job? What do your job prospects look like, and what is expected of you?
That's helpful. Thank you. Melinda did have a question. Can social workers on your team help employees find legal help to hold industry accountable or secure funds for treatment? Or I guess other than the clinical side, like, is there like navigation throughout this process, or like who else is involved?
We have like 3 health nurses, and we don't even have a social worker for a hospital. We have it's difficult to find actually a person that has like a bachelor's or is a licensed social worker. And a lot of those resources are towards oncology navigation and patient navigation. And so the Iowa Workforce Development is a referral. So if I feel like an employee has been wronged, with like a worker injury or something, the reality of the situation is that it takes a lot of money. It's going to be 3 years before you get a hearing, and nothing may come of it. And so it's not to be, my gosh, it's loud. You turn, just turn. So a lot of it, I think, there's a volume up. Oh, sorry, I'm very scared. I woke everybody up. A lot of it, I think, is
Yeah.
a lot of it, I think, is what resources does the state have? It tends to be employer friendly in certain states, but also being upfront with the individuals that saying like, is there enough evidence here? You know, this is kind of what you're getting into, and if it's your fight that you want to fight, be more than happy to kind of accompany you and do what I can. The problem is that the legal system is expensive, and ultimately, a lot of the workers' comp cases, not just environmental health ones I've seen, is that they end up being just a lawyer's kind of win. After 3 or 4 years, it's very expensive, and neither side's really happy. And on the environmental side, there's a lot of pro bono work, but it's just very limited in rural, and it's limited in some of these smaller areas. And so there is online things I've looked at, but generally we are the biggest patient advocates. We give them all the resources I kind of put together online, and we kind of go through and saying like, here are your options. And it's sad because sometimes people really do have or they were wronged. There was, but there may not be enough evidence in the literature to even support something. And so I know that's the first thing that the lawyers are going to go for or whatnot. And this is unfortunately the reality of this. And you look at Flint, Michigan is a great example of that.
Any other questions for Arthur and Dr. Life? We've got time. Or if anyone else also works in these spaces and has anything to share, feel free to unmute. I was curious to hear more about using electronic health records. I don't know, like, I guess either to identify patients who may have that like cumulative risk or just mixed exposures, like how do you maybe intervene there? Or I guess, or what other uses do you have for the electronic health records?
Yeah, so a lot of if you're measuring it, and so a lot of it's understanding what is in the EHR. And so, for example, we have like a screening that we've implemented for social determinants. And so I could run kind of queries in our EHR and figure out, are there actually disparities? And what do these disparities look like in our patients that we see? There's not a lot of environmental screening that's filled out. One big one is smoking. But you look at employment one is like, are you employed or not? Is it more, it's more kind of financial versus actual risk exposures. But I think that the takeaway is that if you have Epic or PowerChart or whatnot, it's definitely worth seeing what's in there, because you can look at epidemiological data and start getting questions and say like, I've noticed that there is a lot of actually brain cancers in this population. Because you look at grants and other interventions, this is like the start of your research question. And you have actual data to support that. And so, like I mentioned, that one physician, I think she was a resident in her training, she just looked at lead levels before and after they decided to move the water. And she found it was like, oh, there you go. The children's lead levels were 2 to 3 times greater in Flint after they moved the water source. And that spurred a whole research, kind of actually a clinical trial to look at and investigate. And that was just because she was looking at the EHR. And so they are powerful. I think there are powerful ways to look at that, and they're very timely because you have up-to-date data. The other thing is that if you're interested in collecting something, it's easy to add into it, and so you can develop a screening. For example, you can develop a screening and have it embedded. So when someone gets roomed or you can promote it. Say like, hey, when you're waiting to get room for your next appointment or whatever, do you mind completing this 2-minute survey from your chart or something like that? It can be all de-identified, and you have actual data to substantiate what you're kind of investigating. So.
Thank you. Yeah, that's helpful because we've had a few partners in the cancer screening space use their EHRs to sort of see who is eligible for, say, like lung cancer screening, but hasn't gotten checked yet, and just how to make those asks. So that's nice to see, like how it can be applied in Occ Health. Liz has 2 more questions. Liz is on fire with questions today. Do you ask patients about radon in their homes? And then I'll ask the second.
I typically don't. A lot of the patients we see are more of the acute type patients, injuries and things like that. So typically I don't ask that. And as far as
It is. I mentioned about radon. So it's a number 2 cause of cancer in older homes with foundation cracks or basements. It's really under recognized in certain areas, and so especially new homeowners. I think we do a better job on the family med side, kind of screening for that and making sure that the environment is safe. We In our clinic, we don't, because we're mostly acute injuries, but radon awareness is a real thing. And a lot of times people learn about it when they're buying a new home and they're like, oh, I should get a radon test, or my inspector said, but was it a valid test? Did you have like actual active mitigation or passive mitigation of it? Because sometimes people don't have the $2,000 to get a new system in. And so, oh yeah, thanks Liz for posting. Everyone assumes it's just tobacco. And so radon really can impact, and you'd be surprised, when I was shocked that, I think mine was 7 or 8, and they're saying like, well, technically you're okay. I'm like, I'm not okay with any radon. And I'm like, I'm gonna, for me, it was worth the investment to have the peace of mind and say, I don't want to get exposed to anything I know of. But our primary care deals a little bit more with that, but I still think we could do a better job educating patients and families on that. And go ahead, you want to answer the second? Oh, sorry, go ahead.
The second
Yeah,
question.
perfect. Have you ever requested a cancer cluster investigation when you start to notice those similar cancers employers coming in?
I never had, and when I was working in the ER, I didn't really even put it together that there could be such a thing. I do remember about 25 years ago, I got a letter when I was actually in primary care from I think it was from Iowa State. And they had noticed, we're going to come up with right now. Sorry. They sent a letter, and several of my patients had cancers. They were young patients, and they sent a letter kind of indicating that this area had a higher incidence of cancers. So I don't remember that they did anything about it, but they were asking about each patient that had cancers. And I never heard any follow-up on that.
I think we don't have the resources. And I had like 5 different hats. Dr. Life was 3 different hats. And so a lot of the things that we should do, we want to do, unfortunately, in rural, and like many of you wear multiple hats. And it's like, what's the burning priority for this week? And so this is an unfortunate thing. So a lot of these longer term exposures kind of get put on the back burner because this happened this week, this needs to get done. And these things kind of over time, that was 20 something years ago. And
at the time, it wasn't as important as it is now.
Yeah. So that's a great point though. Yeah. It's, so no, We haven't done any investigating, shame on us, so not yet.
I would like to.
Yeah, we would like to, yeah, I think a lot of things.
In the industry.
There's a volume, just go.
No worries. Well, you guys are doing the best you can, so we appreciate it. Yeah. I guess that kind of ties into one question I had, because you mentioned family med and like primary care. So I'm just curious, on our side, I'm starting to see literature on like the occupation of the parent and their exposures impacting the health of the children in the home, if there are children in the home. So I'm just curious, have you had any cases like that where it turns into like you're looking at a whole family? Or like, does that come up a lot, like asking about children's health while in the occupational health setting?
Not, I don't think
Yeah.
not so much for our clinic, because we deal with very, I guess, niche industries here, at least
Gotcha.
locally. Most of the things that exposures are molds. And I think there was one where we do aspergillus to see if people have sensitivity, because they may have to collect samples in mold, in kind of fungus, settings at the work. And so they are getting sensitized to it. They can have a kind of a really nasty immune reaction. But the individual, I remember, we couldn't pinpoint if it was work exposure or home. And it turns out they were living with like a lot of mold in the basement. And actually, we got a little bit asking, has anyone else been sick at home or whatever? Oh, actually, you mentioned it. Yeah, my cat, my two kids, my wife. I'm like, when I asked you, like, and I asked you for the last, 3 visits, and sometimes people don't, they don't put all that together, but they think that, all molds are the same, or this kind of, they Googled it, they Google lensed it, and they assume that this mold is okay. And it must be my work that's causing me to get sick. When the work is a much more regulated environment sometimes, and it can be a good kind of benchmark to say, maybe this is not it. And so, but I think the biggest thing is like lead in our area, water quality, and understanding what water testing is. And that Flint, Michigan thing is like, well, just because the water treatment facility is testing the water and saying it's fine, it doesn't mean all the pipes it gets through, and then the plumbing of the house means what actually is going into your glass is what you're getting and is what has been tested. And so I think a lot of it is understanding what these reports, how they were collected, and are you actually safe? And so some of the family med, I think that's a lot of it we look at is like water, lead, the really older, because a lot of the older homes, and asbestos, especially they're doing construction. So
I can ask questions all day. I'm starting my health degree in the fall. So, but I'll,
keep
in
touch.
I will, but I will leave it to the audience. If anyone has any questions, comments, compliments, give them a sec. Well, one thing perfect. Okay. Just lots of thanks and praise. One thing I was curious about, because you mentioned like how it took you 3 to 4 visits to get that information out of that one patient. Like, do you have any tips for like just how to ask questions or how to conduct those like assessments, like to either get more information out of people or maybe get potentially sensitive information out of people?
I think you just have to start questioning them and see if there's connections like to their environment at home, and just keep going down for the positive answers that they have, and just keep searching for if there's a connection between the illness and what their environment is, either at work or home.
I think the biggest thing too is if a patient feels that you're an advocate for them, I always say, I work for you. Like, I'm here for you. And so I don't really care what the company, I'm pretty straightforward. Like, I got into help patients. And so, because sometimes there's nasty side of business. And so I kind of diffuse that right away. It's like, I'm not hired. I don't work for I am here to serve you as a patient. And so when I start asking questions, it automatically kind of puts us on the same team and we kind of start looking at things together. So I think, if you're not very empathic, I don't know why you're in healthcare, but I love it. If you kind of remember that and you kind of work off of that, it's like I'm in it to help that person. And I may not have all the answers right now. So it's going to be a collection of data, and it can be from, different questions I ask them, different things they're telling me, physical findings, tests. And so I think if you're genuinely empathic, even if you're not, then at least say you are, or that you're an advocate for them and that you want to get to the bottom of this. And that kind of also helps them be a little bit engaged too, because it puts a little bit of responsibility and accountability on them. I don't live with you. I don't go to work with you. I see you for 15, 20 minutes. You gotta help me. I can play 1,000 questions all day. I'm not Dr. House. And so like most of the time it's common things are common. And so if you're constantly looking at zebras and wasting time, they kind of get disinterested. And so I think I start kind of broad, engage them, you're ultimately trying to help them. And so if they feel that, I think they'll be kind of more invested. And also not to scare them. I don't want to start talking about cancer right away. It could be a million things. I have no evidence. So why would I say that right now? And because you don't want to send them to Google searches, because then they'll be calling your clinic and asking all sorts of things that you open the can of worms. Or they start looking at their employer as someone that's poisoned them when you have no evidence of that. And so I think, in the beginning, you're kind of doing some almost like detective work and putting things together.
That's a really, really great point because, we're the Iowa Cancer Consortium, but when we're looking at like environmental and occupational exposures to things, cancer is one endpoint. There are many other paths that, or routes of exposure that can lead to different health outcomes. So thank you.
I would add,
yeah,
I would ask one last thing. Rural culture. Know your community and context. Rural culture is its own phenomenon. So understanding that certain, males tend to do X, Y, and Z, especially farmers. They will minimize things or they can't miss a day of work. And so there's a lot of these determinants that impact health decision making. And so you have to be aware of the context where this patient kind of exists. They're not this, not every patient's the same. They have different worldviews, they have different lived experiences. And so the more you can kind of appreciate those differences, the more likely they are to engage with you. If you're not really respectful of that, they see that you don't understand how they live. And they're like, well, who are you to tell me X, Y, and Z, right? And that partnership kind of breaks down. And so understanding the culture of where you practice and who you're working with is fundamental, I think, in this day and age. So
yeah.
Sorry to cut you off there, Kelly.
No, that's a really important point because what we're trying to at least get out to everyone is that the environment can be nature and trees, but it can also be built and cultural norms too. So really, really important point. Thank you. I did want to close with one question for both you and Dr. Life. What role do you see cancer control and public health professionals playing just in occupational health safety, in normalizing, conducting an exposure history for cancer risk reduction?
Okay.
I have to think about that.
So I think a lot of it is public health is facing an identity crisis. And so we both work in public health. And so, it's underinvested, it's being de-invested for decades. And so it is really difficult. And so I think the biggest thing to look at, and then what we're looking at exposure-wise, is where can we kind of combine worlds? We're seeing in our occupational medicine clinic, and then looking at the bigger kind of community context where some of these exposures sit in, and how we can intervene at the population health level. And so one of my biggest things is health literacy and empowering individuals kind of through knowledge and understanding how they make healthcare decisions. So when I see them, I may be able to talk about 3 to 5 minutes about smoking cessation, and they may be for a DOT exam. You're like, why is this guy bothering me about this? I always tell them, you can never say no one told you. I took 3 to 5 minutes, and you can never say that you never were, because decades ago, they were lied to. A lot of these individuals started smoking. My father stroked because of smoking. And so a lot of that is like, how can you kind of tie in these public health and really preventative things into your practice and what you're passionate about? There's I think the next 5 to 10 years of public health is gonna be greatly changed, and a lot of it's gonna be focusing on environmental exposure and cancer. But what that looks like and how it's gonna translate to clinical and healthcare, I don't know. I don't know if you have anything else to add to that, Rachel. No.
You said it all.
Perfect. Well, thank you both so much again for taking the time out to share your experiences and just talk about your work. And thank you to everyone who joined today for, again, our last part of our summer webinar series on strategies to reduce environmental cancer risk. And I'm really happy we were able to close out with Dr. Life and Arthur, because I think being able to talk about exposure histories and explain, just know what's around you when you're at work, when you're at home, things like that are really, really important. So just thank you both again so much for taking the time out to present. For folks who have attended this session or just any of the sessions, there is an evaluation available. So I will post that in the chat. It's just a brief survey. Let us know what you think. Was there something we didn't cover enough? Would you like to see future meetings? Just let me know. And there will be an email sent out to all registrants for all 4 parts with recordings and additional resources like the ones shared today. So with that, happy Tuesday, everyone. Thank you again. Virtual round of applause for Arthur and Dr. Life. Really appreciate it. And please feel free to reach out with any additional questions or thoughts you may have. Happy to get folks connected with speakers. If anyone's looking to start their own occupational health program, I'm sure.
Don't do it. I'm just kidding. I'm just kidding.
No,
But ask us.
it's a great field.
Yeah, connect with us, and thanks
Yeah.
again. Thank you so
Yeah,
much.
thank you. Thank you. Enjoy the rest of your day, everyone.